Thanks, Paul. Real pleasure to be here. I hope you can see my slides. Hello. Paul, can you see my slides? Hello. Paul, I can't hear you, so I don't know if you can hear me. Hello.
The slides are good. Go ahead.
Okay, great. Okay, great. Okay, thanks, Paul. Thanks for that very kind introduction. It's a real pleasure to be here. I wish I could be in Singapore in person, but sounds like you have a problem with COVID and lions now on top of the humans and everything else. So, and there are challenges obviously back there, but it seems to be the way of the world. So I wanted to first set the context of what we're talking about in the context of COVID, because secondary bacterial infections have always been known to be a challenge during the times of influenza pandemics, going back to the 1918 flu pandemic, where a majority of or at least a major part of the influenza-associated pneumonia and deaths were also caused by pneumococcal infections. And this has been noted from tissue culture studies, which went back and looked for positive cultures for pneumococcus, and in patients with pneumonia, it is more likely that they would be positive for the Staph aureus bacteria. Now, keep in mind, of course, that at that time there was really not any treatment for pneumococcal pneumonia, and so this is in the pre-antibiotics era. But in some sense, we are back in that situation today where many people, perhaps not in Singapore, but other parts of the world, don't have access to antibiotics or effective antibiotics. So what we call the problem of drug resistance is first and foremost today also an issue of lack of access to effective antibiotics, which is what distinguishes different parts of the world in terms of what the burden of AMR is. Now, if you looked at the time to death and the proportion of deaths from influenza-related pneumonia deaths, and then the pneumococcal pneumonia deaths in 20s and 30s, you can see that the pattern was extremely similar. So this is not direct, but it's circumstantial evidence that a lot of the influenza-related pneumonia deaths were also, probably driven by secondary bacterial infections. And now, jumping forward to the COVID pandemic, which is really the place we should start any such discussion, given what we've gone through for the last 2 years, perhaps the first study to look at antimicrobial prescribing. So I want to walk through antimicrobial prescribing and then resistance during the course of the COVID pandemic, and then get to what the global and the local situations are. This was a Scottish study which was looking at respiratory tract infections, amoxicillin, azithromycin, clarithromycin, Comax, Clab, and Doxy, and non-respiratory infections. And what you can see very clearly is that in 2020, after a spike during the initial period of COVID, respiratory prescribing has actually generally gone down in community settings, at least in Scotland. So the y-axis is number of e-prescribed items. Now, if you look at the United States, it's even more stark. So if you look at retail pharmacies and the number of patients with antibiotic prescriptions, it was sort of modestly lower in January, February, March. But in April and May, there was significant declines in antibiotic prescribing. And this could have been for a number of reasons. One is that people were unable to access healthcare because of COVID restrictions. Another reason is simply that the number of respiratory infections, which drive a lot of the prescribing, went down because people were in their homes, or there were movement restrictions, which then stopped the spread of other infections, which potentially could have resulted in an appropriate decrease in antibiotics as well. So this 42% is probably both an appropriate and an inappropriate decrease, but we don't see a huge number of increase in deaths or bad outcomes from things where people ought to be getting antibiotics for that same period. So this also gives us some sort of an indication of the total proportion of community prescribing that is potentially not needed at all, but which could be averted without any significant health impact. And this is quite significant, as you can see, and probably it would be even worse. This is, again, the same thing, which is the number of unique patients with prescriptions from retail pharmacies for all antibiotics and then for azithromycin. And you can see that it's dropping, but it's dropping even more significantly by almost a factor of 4 for the Z-Pack kind of prescriptions, which really are what every patient well, not every patient, many patients demand in the US. And this is where a lot of the bulk of the inappropriate prescription is really happening. Now, if you look at, again, the observed versus the expected number of patients dispensed antibiotics from retail pharmacies, and these are per 1,000 persons on the y-axis. Again, look at January, and this is the amount that you would expect in May, and this is the amount that you actually get in May, compared to May, in each of the age groups, 0 to 4, 5 to 19, 0 to 19, 20 to 64, and above 65. You can see that a lot of the decreases actually seem to have happened in the younger age groups, which we know from earlier studies who are also the subject of inappropriate prescribing. And COVID seems to have really dropped that number significantly, not so much for the elderly population, who may actually have, reasons for getting the antibiotics given, reduced immunity or other reasons for needing the retail prescription. Now, if you look at data from across all hospitals, you can see the change in prescription of different kinds of drugs, not just antibiotics, but importantly, you see hydrochloroquine, which inappropriately just shoots up massively in March, April after some of the flawed studies that have come out. Azithromycin did go up, but not quite as much as hydrochloroquine. Now, dexamethasone is actually slightly lower, but of course, once the study results from the recovery trial come out, then that goes up, and amoxicillin also goes up, but not by a huge amount. So you don't see a significant increase in prescribing, although in the initial part, because of that study which showed a decreased SARS-CoV-2 load with co-prescribing of hydrochloroquine and azithromycin, and this emergency use authorization, you saw the use of both those go up, but then that sort of fades away after that. And again, if you look at the top versus the bottoms, this is the total antibiotics in 2019. That's all the dashed lines. Sorry, and the solid lines are in 2020. And these are for ceftriaxone and azithromycin. So orange is ceftriaxone, and this red line is azithromycin. Ceftriaxone use was actually 43% higher in April 2020 than in 2019, and azithromycin use was much higher, and then it bumps up again, ceftriaxone stays down. Whereas if you look at total antibiotics, 16% decrease in residents with antibiotics. These are from nursing homes, I should say, not healthcare institutions. These are from nursing homes in the United States. And these are studies this is a study out of India, in fact, which looked at prescribing, and you can see that in India, the total the COVID cases actually peaked in September of last year, and this is what you see in all of the charts. But you see a peaking of antibiotic prescribing as well in India, coinciding with this COVID peak. Now, in this study, they didn't really compare this with previous studies, but you see an immediate takeaway, which is that so the non-CAF is children-associated prescribing versus non-children associated prescribing, and you can see that the non-children associated prescribing went up significantly. A lot of adults were getting antibiotics, but it really shows that there's a big difference between what has happened in developed versus developing countries, at least at this very, very gross scale. If you take India as an exemplar at one end and Scotland as an exemplar at the other end, that the changes in prescribing, there was actually a decrease in high-income countries, but in India, there doesn't seem to have been a decrease, and in fact, there seems to be an increase in prescribing as a result of COVID last year. So COVID likely contributed to about 216 million excess doses of total antibiotics and about 38 million excess doses of azithromycin alone, between June and September of 2020, which is right after the lockdown and until the epidemic peak. So when when people ask, well, did you see antibiotics go down or up around the world? And the answer is the evidence is really quite mixed. It depends on the country you're really talking about. And this is a study from East Asia, I believe from Hong Kong, which again did not see a huge difference in the kind of prescribing between 2015, which is the very bottom, 2017-18 into 2020. A slight decrease in the proportion that were given to penicillins, cephalosporins remaining, roughly consistent. So there wasn't a significant decrease in the patterns of prescribing, at least from Hong Kong. Now, if you look at co-infections and super-infections in hospitalized patients with COVID-19, this was a retrospective study uh, that was done with 989 consecutive patients. There were only about 51 patients with hospital-acquired bacterial superinfections. Most of these were Pseudomonas and E. coli, and diagnosed in about 43 patients. So you see that, yes, there were patients who did get secondary bacterial infections and hospital-acquired infections, but overall, it seemed to be modest in terms of number. However, mortality was high. Overall mortality was, just less than 10% in patients with community-acquired co-infections and hospital-acquired superinfections. So it seems to be that your outcomes are not that great if you get the co-infection, but you don't really get the co-infection quite that often. Now, this is actually a study out of India, which then compared across all these different countries in terms of published data on prescribing secondary infections in COVID-19 patients. And by and large, you again see the same picture, which is that most of these studies are from the US or from China, that except for a couple of exceptions in Chinese studies, by and large, it was a fairly low rate of secondary infections compared to what one might have expected. Of course, some are higher. In this one US study, it seems to be sort of higher, but not all of them had looked at clinical outcomes either. That needs to come in the next sort of, slide. And the resistance profile seems to be quite similar to what you would see. This is data from India. Now, these all seem like very high rates of resistance and clinical isolates causing secondary infections in COVID-19 patients. But you have to remember that in India, the background level of resistance is already quite high. So whatever you saw there is really what you saw got reflected in COVID-19 patients as well. And in fact, if you look at secondary infections in hospitalized COVID patients, you see the same patterns, large proportion of Klebsiella, Acinetobacter, and Pseudomonas, the three big ones that cause, in any case, the bulk of secondary bacterial infections. Now, the story is similar, which is that only about 3.6% of patients develop these secondary bacterial or fungal infections, but the mortality was significant. The mortality was 56% against an overall mortality of just about 10.6% in total admitted COVID-19 patients. Now, keep in mind, the study size is pretty significant. It's about 17,000 patients. So you don't see large numbers of secondary bacterial infections, but when you do see them, then the outcomes seem to be, pretty bad. So I think overall, this is of concern because it's something which tells us that secondary bacterial infections are quite important. And the bottom line is the evidence on overall prescribing is mixed, is decreased in community settings in high-income countries, but increase in those settings in India, and increase in hospital settings in many countries, although it was much more in the low-income, in poorer countries than in wealthier countries. Now, one thing which I didn't really get into was evidence on infection control compliance. There's a lot of anecdotal evidence on mask wearing and hand hygiene in community settings. Surprisingly, not that many studies that are actually showing levels of infection control compliance. We have evidence, from many countries, including high-income countries like Switzerland, showing that healthcare-associated COVID transmission was a significant problem. So again, we have those kinds of studies, but again, not tied to any sort of measure of infection control compliance. But I hope that these studies will come. For secondary bacterial infections, they reflected, underlying levels of infection control. There wasn't necessarily a significant difference in the proportion, although we have to add that when one did get a secondary bacterial infection, the chance of survival was much, much lower. Now, what COVID did was, I think we can all agree, apart from being a disaster for the world at large as far as health went, does seem to have improved at least personal safety measures with like mask wearing, which I think will be hard to sort of dislodge for some period of time, and also increased in many populations acceptance of vaccines. Now, many high-income countries take for granted the idea of adult vaccines. Whether for shingles or for seasonal influenza. But in many countries around the world, the idea of adult vaccination is just not known. But we do know that vaccines are a great way to prevent AMR. In fact, I'm going to show you a set of studies where during the COVID period, we had an opportunity to really look at carefully the effect of vaccines on AMR. Now, this is an older study from Cure et al., which looked at the introduction of the PCV7 vaccine and the reduction of both penicillin susceptible and penicillin non-susceptible disease back in 2000. And we know that the routes by which vaccination can reduce AMR are twofold. First of all, vaccines result in fewer infections, and these are vaccines both for viruses and for bacteria. And when they are for the bacteriums, when they have vaccines against the bacteria, they lower the disease burden and they reduce transmission, which results in lives saved. But it's also possible, if it's a vaccine against a virus, that it reduces the antibiotic use and reduces selection pressure, which then results in lower resistance and which also results in lives saved. So vaccines, whether against bacteria or viruses, can both help in terms of reducing antibiotic resistant infections, either directly or indirectly. Now, these are the percentage of respondents in these countries who responded positively to, if there's a COVID-19 vaccine, it's safe and effective and available, I will take it. And, we might be concerned that, oh my God, it's only 54%. But you see the other end of the scale, 88% in a country, in countries which where there really hasn't been adult vaccination, significant acceptance. India is another good example, over 75%, or now it's 75% acceptance. These portend really well. And even in countries where the number seems to be lower, like France, it's only 58%. France is a little more vaccine hesitant than average for Europe, but the vaccination coverage right now shows that it's really quite remarkable. That I think that one of the positive blowbacks of COVID on AMR will be potentially an acceptance of vaccines and potentially an acceptance of adult vaccines, including for seasonal influenza, which could have a remarkable effect on AMR. So when we look forward and look back, we might want to think of the things that we can take forward positively from COVID-19, and this would be one. And of course, the PCV7 doesn't reduce just the number of cases, it also reduces antibiotic prescription, starting from the year 2000, and ambulatory care visits as well. And these are data from the US, but they are, the same evidence that you see from other countries where PCV was introduced. And we do see that the flu season was a key driver of antibiotic consumption. The peak month for consumption around the world is, essentially the winter months. In the northern hemisphere, it's January, February, and in the southern hemisphere, it's July, August. And of course, in the tropics, it's sort of, either there is no seasonality, or in a country like India, where there are really, sort of two flu seasons every year. But nonetheless, the flu season is the biggest sort of global driver of antibiotic consumption. And if we can really focus on using vaccines, this is a potential pathway for us forward. In fact, in the United States, influenza is nearly perfectly predicted by antibiotic sales data, which is quite shocking if one thinks about it, because it's the large proportion of these are inappropriate prescribing. But if you knew the prescription data on antibiotics, you could, almost perfectly tell what the flu trends were. And keep in mind, the flu trend data is not readily available on a daily time scale in the US. It often gets reported, weeks or months later. But this also happens to be a good way of telling how bad the flu season is. Now, this is the set of studies that we had done looking at vaccination and antibiotic use, or on resistant infections. This is the first of these, which looked at impact of influenza vaccination and antibiotic use. And what we found was that a 10% increase in influenza vaccination rate was associated with a 6.5% decrease in antibiotic use, which was quite significant, even in absolute terms, about a 14.2 fewer antibiotic prescriptions per 1,000 individuals. And it was most important in pediatric populations and the elderly, places where we do think that there's a lot of inappropriate prescribing that's going on. This was a study that was published in Nature last year, which looked at effect of introduction of pneumococcal vaccine and also the rotavirus vaccine on antibiotic use in low and middle income countries. And what we found was that these two countries conferred a roughly 20% and 11.4% protection against antibiotic treated episodes of acute respiratory infections and diarrhea. That's the pneumococcal and the rotavirus vaccine. And these are obviously the age groups that for which antibiotics are given out the most. And overall, you could prevent about 23.8 million episodes of antibiotic treated illness in children under 5 because of pneumococcal vaccine, and about 13.6 million episodes of antibiotic treated illness with the rotavirus vaccine, and total another 40 million episodes, which is I think great value for money on top of the direct impact that the vaccines are having on illness. This is just the effect on antibiotic use. This was the largest study that has been done till date at that time. This is published last April. Of course, came in the middle of COVID, so it didn't get as much attention. But you can see that the attributable fraction of vaccine preventable infection is pretty significant, and particularly in middle-income countries. It is there in low-income countries as well, but pretty significant in middle-income countries where your vaccine efficacy also tends to be greater. Now, we did the same thing for tuberculosis as well. Of course, for TB, we have the potential vaccine which could prevent rifampicin-resistant tuberculosis. But even here, we found that in just the 30 countries that account for most of the tuberculosis, a future TB vaccine could avert about 10% of rifampicin-resistant cases and about 7.3% of deaths over a 15-year period. And most of these are going to happen in India, Nigeria, China, Russia, and Indonesia. And this is, again, having that M72-like vaccine and compare that with improved rifampicin-resistant management and incremental effect of the M72 vaccine. So certainly, having that improvement and doing more with the vaccine is really the way to go, because then you do even better than what you would with just the vaccine alone, because the vaccine's efficacy is not high enough to depend only on the vaccine. So what we really should be doing is the combination of the vaccine, and certainly there are some countries where there's not going to be a huge gain from that, but some countries which you would actually get a significant gain from both those measures. Now, sorry, I'll just move to this. So when we look across the world, and these are data that were published in something called the State of the World's Antibiotics Report, the global antibiotic use and resistance has actually changed over a period of time. This is looking at high-income countries, low and middle-income countries. Penicillin use tends to be lower there, but overall resistance does seem to be higher in low and middle-income countries than in higher-income countries. We also see that the drug resistance index, which is like a weighted average of resistance, weighted by how frequently antibiotics are used to treat them, is pretty high in many countries. India is persistently on top of the scale. Obviously, the Scandinavian countries are generally at the bottom of the scale. But this is a single measure of how bad resistance is, and is a measure that we've sort of pushed to track resistance and also to communicate it to lay audiences. Total antibiotic use has been increasing over time. I apologize, it should be Francophone West Africa, not French West Africa, and has been going up, although it's not going up everywhere. In China, it's sort of flattened out and decreased a little bit. In Brazil, it's gone up, and Saudi Arabia also, it has gone up. If you look at the national consumption of access and watch antibiotics, access, of course, the antibiotics that people should have access to, and watch are antibiotics that should be on formularies, you can see that there's been a decrease. The blue indicates a decrease in the access antibiotics around the world, but worryingly for countries like India and Pakistan as well, and China, whereas the watch antibiotic consumption actually gone up in these countries, in very large countries, also in Brazil. So in Brazil, both access and watch have gone up, but in India, it's the watch that has gone up. If you look at consumption in animals, you can see that there has been an increase over a period of time, again, from the beginning of the century to 2030. The bulk of antibiotics are in pigs. Mostly these pigs are in China, and then also in humans. The fish account for very little of this, and cattle and the cattle and chickens are a lower number actually compared to overall humans and the pigs. And meanwhile, something which the clinicians don't worry about, but we do see that there has been an increase in antibiotic resistance in animals itself over that period. This was published in Science about 2 years ago, and we see increase in chicken resistance in chickens. This is a proportion of drugs with 50% resistance having gone up, more than twofold in chickens and pigs, not a significant increase in cattle. So we worry about resistance for the sake of animals themselves. And there are policies to reduce antibiotic consumption in food animals, and these can be implemented. And this really should be a focus for the world, but not yet happening at scale. Antibiotic development, on the other hand, there has been some improvement. You can see this situation in 2013 and the one in 2019. Many more of the drugs that have moved from phase 1, phase 2 into application or approval. That is good, but not good enough. And finally, in this report, which I urge you to read, it's on the CDEP website. So this is the state of the world's antibiotics. What we've really moved for is a national level look at resistance, which is based on the quality of surveillance on antimicrobial resistance indicators, which are in humans, also in animals, antibiotic use indicators in humans, also in animals, and then public health indicators and other indicators. We believe that looking at resistance just in terms of proportion resistance, which is just this part alone, is incomplete unless you have a full dashboard view. And I think it's time we really started doing this consistently in a One Health sort of a way. We've done this now for over 70 countries, and I'm just showing you a few exemplar countries so that you can see how we can go about doing this in a consistent manner. And last, just to conclude, I think COVID has increased the acceptance of adult vaccines. I think we should leverage that. The pipeline for new antibiotics is getting stronger, but very slowly. We need to push that. And I think we need to really accept that One Health is really our way forward for all infectious or zoonotic pathogens, but AMR particularly, given the proportion of antibiotics that are headed to animals. So I will stop here and just say that if you want to see the data, they're on the CDEP website or at resistancemap.org. And thank you so much, Paul, and the organizers of this meeting for having me. It's been a real pleasure being here.